so I just made a funny little meme so that you guys could see this is going to be a light presentation, and we're really going to talk about things that we can tell our patients, as well as things that I try to incorporate into my life and I tell my family as well. And so, I think I like this diagram because really, if we talk about whatever disease, cardiovascular disease and cardiovascular kidney metabolic syndrome is really what we're talking about today. But a healthy lifestyle is really how we prevent disease throughout life. And so this applies to not only CKM, but it also applies to AFib. This is actually from the atrial fibrillation guidelines. And so I like to just show this to say we're all treating the same disorder, no matter if we specialize in AFib, if we specialize in hypertension, if we specialize in diabetes, or we specialize in ischemic heart disease. And so really, it really is a multidisciplinary approach. And so it requires all members of the team. So I'm really glad we have a multidisciplinary team here. I just threw this in here because this is really when we started talking about this, a lot in the United States as far as a framework. And this was a presidential advisory that came out because really over the last 20 years, we've seen that obesity rates have skyrocketed. And as obesity rates have skyrocketed, so has cardiovascular kidney metabolic disease. And so we've already talked about this, so I'm just going to briefly go through here. But I do like to say at stage 0, hopefully this is where most of us are. And stage 0 really means that we're focusing on prevention. And so it's really a focus on primordial prevention. So we want to not only prevent cardiovascular disease, but we want to prevent those risk factors that we know increase cardiovascular disease. And so hopefully we're here. But, I think this whole concept of CKM is so important because we meet people, unfortunately, over here in stage 4, the majority of the time in my office or when I meet people in the hospital. We know, though, that stage 1 or dysfunctional adiposity is really where this starts. And so at least calling this a disease state, I think, puts it all into focus. So I think Rosa Maria did a great job already in talking about that. So I'm just going to briefly go through. But we know that anytime we have ectopic fat, and ectopic fat is really fat that is anywhere it shouldn't be. So it's visceral fat, it's fat in our liver, it's fat in our muscles, it's fat around our heart or pericardial fat, it's fat around our kidneys, our pancreas, or around our neck. All of those areas, we should not be storing fat. Subcutaneous fat's a little differently. Subcutaneous fat, we can kind of put on and take off, and it doesn't necessarily associate with bad things. But this ectopic fat associates with, this whole pathway, which really centers around adipokines and inflammation, and really from our standpoint, from CKM standpoint, relates to atherosclerosis and cardiovascular disease, heart failure, stroke, hypertension. And so the deposition of ectopic fat is really what we want to get away from. And again, this is some more of the mechanistic parts that we've already gone over. So I'm going to just kind of briefly go through and skip those. But from an observational standpoint, we've known from a long time. This is from, 20 years ago now, but from Framingham, which looked at subcutaneous fat or visceral fat and periaortic fat and pericardial fat. And what it said was, if we see visceral adipose tissue as the tertiles go up, so does our likelihood of developing cardiovascular disease. Framingham has a lot of problems. It's largely a homogeneous population of white individuals in the Northeast United States. And so if we look at other groups that are more diverse, like the Dallas Heart Study, we see the same thing. We see that as visceral adipose tissue goes up, so does our risk of cardiovascular disease. And we saw the same thing in this study. Subcutaneous adipose tissue really does not track with cardiovascular outcomes. And we can see similar graphs like this with pericardial fat, with neck fat, with intrahepatic fat. And when we start looking at those risk factors, we know that there are many that we've already talked about. We see increasing age, we see more of this. We see it is associated with hypertension, levels of inflammation or elevated inflammatory markers. And it's also associated with poor nutrition, sedentary lifestyle, a processed diet, and obesity. So, when we talk about different constructs of what is a healthy lifestyle, Life Simple 7, which is one of the things the American Heart Association focuses on, I think is a really easy one to think about in our lives and with our patients. It's now Life's Essential 8 because we added sleep in, but with Life Simple 7, it really is stop smoking, eat better, get active, lose weight, manage blood pressure, control cholesterol, and reduce blood sugar. And then we can give points for each of those. And if someone is ideal in each of those categories, they get 2 points. If they're intermediate, they get one. And if they're poor, they don't get any points. So if we go back and we look through Life Simple 7 and we just say, if we follow people and look at their risk of heart failure over their lifetime, and we start at age 45 to 64. Now, there's lots of other metrics this looks at. I chose heart failure, but you can also look at stroke. You can look at coronary artery disease. You can look at chronic kidney disease. You can look at liver dysfunction, and they all track very similarly. But if we have inadequate cardiovascular health, we have about a 50% increased 50% incidence of developing heart failure. That's compared to average cardiovascular health is about half of that. And with optimal cardiovascular health, it's just about 14%. So simple things that improve our overall health really reduce our risk of developing disease as we age. Weight, I think, is one of the most important ones. And there's lots of different ways to look at weight. There's body mass index, there's visceral adiposity, there's waist circumference. But all of these, if we follow trends, what we see is that as we go from normal weight to overweight to obese to severely obese, our likelihood of developing heart failure, coronary heart disease, stroke, or any of the cardiometabolic outcomes increases. So we know weight, in whatever way we look at it, is a metric for increasing cardiovascular disease. And if we look at lifetime risk of cardiovascular disease in both men and women, we can see that the longer we fit into one of these categories, the higher our risk is. So if we're morbidly obese for a longer period of time, that increases the likelihood we develop cardiovascular disease. We also know that weight tracks with all of the individual clinical endpoints we talk about. As our body mass goes up, as our body mass index goes up, so does our likelihood of developing high blood pressure. So does our likelihood of developing dyslipidemia. So does our likelihood of developing type 2 diabetes or impaired glucose tolerance. And this really looks at waist circumference. So if you take, and this was in women, but if your waist circumference was less than 28 inches as compared to more than 38 inches, we had a 25 times elevated risk of diabetes compared to less than 28 inches. So really that concept of visceral adipose tissue and disease risk. And it's generally because we think of obesity as being associated with a variety of other states that increase our risk. So we've already talked about inflammation, poor diet, hypertension, physical inactivity. So it's probably not just one of these. As we pointed out, 90% of the population in some countries fall into the stage 1. It's probably the culmination of each of these risk factors together that really associates with our elevated risk. And so if we talk about normal weight metabolically healthy, which means your BMI is less than 25 and you don't have any risk factors, and we compare that to metabolically healthy obesity, meaning our BMI is over 30, but again, no other clinical risk factors, we still have an elevated risk of cardiovascular disease and coronary heart disease, stroke, and heart failure. And so the concept that we have metabolically healthy obesity is probably not true for the overwhelming majority of people. This, again, is an observational study following people over a long period of time. And again, obesity has lots of different effects on the cardiovascular system, including increasing our risk factors. So that stage 2, increasing the risk of atherosclerosis, increasing the risk of heart failure, specifically heart failure with preserved ejection fraction, increasing the risk of arrhythmias as well, and AFib predominantly. And if we think about weight loss, how does that change our risk factor sum? This is, again, old data from Framingham, but it followed people for 20 or 16 years. And it says, what happens if a man gains 2.25 kilograms over 16-year follow-up? And what happens to the risk factor sum? It increases about 20%. And for a woman, it increases about 40%. And I think in the big picture of the world, we're thinking of about 5 pounds. That doesn't seem to be that much weight. But what happens if we lose weight? If we lose the same amount, if we lose 2.5 kilograms, it decreases the risk factor sum of men about 50% and women about 40%. So I think when we're talking about weight loss from an overall cardiovascular and metabolic standpoint, it doesn't have to be large amounts of weight loss. We can see significant changes with as little as, 5% of our body weight. It depends on what our BMI or overall weight is starting out, but really weight loss is one of the primary factors that we look at. And then if we're talking about, looking at just following people longitudinally over time, this is from the Nurses' Health Study, but if we had a normal body mass index, daily activity of about 30 minutes of moderate walking, and followed a DASH type diet or a low sodium, largely unprocessed diet, we had about 50% reduction in developing hypertension. And when we think about how common hypertension becomes in women, 75% by our 70s, it really makes a difference. And if you look at the number of healthy lifestyle factors, as those increase, the risk of developing hypertension goes on down. So a healthy lifestyle, things like ideal weight, regular activity, low salt diet, really decrease our likelihood of developing cardiovascular risk factors. So I love this concept of the blue zones. And so I thought I'd put some of this into this blue zone concept. And so the blue zones, really a social construct that was in National Geographic probably 20 years ago now, but it looked at places around the world where people lived the longest free of disease. And they went to those communities and they said, what do people do in these communities that is similar? Because it's different genetics, it's different lifestyles, it's different cultures. So what is the common threads that we see across the blue zones? So across the blue zones, and Dan Buettner was a social ecologist and that initially did this, and he looked at population density of nonagenarians, or centenarians, sorry, and where they had the highest density is where he called a blue zone. And there was 5 of them that he initially described, and he went to each of those places and he said what happened in those places. And he came up with this concept of the Power 9. And I really like this, and I think patients like it. It makes it easy for me to talk about to them. And so we're going to go through the Power 9. So the Power 9 starts with move naturally. And so it really has people, and it talks about let's move our body in any way we can. And we know from our own scientific data that physical activity is one of the strongest predictors of mortality and cardiovascular risk of anything we look at. And I really like this graph. It's one of my favorite graphs in all of medicine. But if we look at this curve and we look at physical activity volume going from no physical activity to very high levels, and we look at cardiovascular risk, if we take someone who gets no physical activity and we get them doing just a little physical activity, what we see is a very large delta change in cardiovascular risk. And then if we take someone down here who's already doing a moderate amount of activity and we get them to do a little more, we continue to lower risk, but we're really getting to the flat part of the curve. So if we can take this concept to our patients who are doing no activity or very limited activity and ask them to try to walk 5 minutes a day, that may be more productive on a population basis than trying to get our people who are doing 30 minutes of walking to get to 45 minutes of walking. So I use this when I'm talking to patients as a way to say, very, very small changes make a huge difference in our overall risk. And it helps combat obesity and dysfunctional adiposity because we increase lean muscle mass. And so that makes our heart happy. Greatest benefits going from no activity to some activity. In daily steps, right? It's hard to not know your steps now because everything we have electronic measures our steps. So if we increase our steps, we all know we say over 10,000 steps is optimal. But what we see is that there's really a continuous association with increasing levels of step counts. So if we increase our steps by 1,000, we see about a 15% reduction in all-cause mortality. And even 500 steps gives us about a 7% reduction in cardiovascular mortality. So increasing activity, no matter where we start, if we're starting from a low level or a moderate level or a high level, we continue to see benefit. And we see that in males and females, and there's really no nadir down here. So 10,000 is great, but you see additional benefit with 15 and 20,000. So if we have someone who's already active, we can get more benefit. But if we really want to see the greatest benefit, we start here at the people who are doing no steps and really get them to do some steps. And we see really profound changes in outcomes. And we see that in males and females. We see that in younger adults and older adults. That relationship holds true. And then we see that if people are sedentary, and this is more sedentary activity, less sedentary activity, even if they're active, that sedentary activity is bad for overall cardiovascular health. So we want to get people sitting less and moving more. And then we know that exercise reduces that visceral adipose tissue more than diet alone. And I think that's really important to point out because we have lots of medicines now that we can reduce weight. But without exercise, we really aren't necessarily changing our body composition. And so this is looking at reduction in visceral fat. And with weight loss, we see it, and this is visceral fat and this is whole body fat. So we see some reductions in visceral fat with weight loss, but when we add exercise and weight loss, we really see significantly more changes in visceral fat. So exercise really is a key not only to improving cardiovascular outcomes, but to reducing visceral fat, which we know drives a lot of the dysfunctional adiposity we talk about. So if we move on from moving, and we talk about purpose, I think this is also really important. In this world we live in, people are very busy and we don't take time necessarily to enjoy life or downshift. And so I think this is something else to think about. And this was a study that looked at MRIs. I'm not going to pretend I know all the data about radial kurtosis, but really what it said is it looked at people who felt like they had a purpose in life, some reason they got up every morning, something that they participated in and contributed to. And what we saw was that improvements or purpose, having a purpose, improved imaging metrics of brain health. What you can see is that as we age, in general, radial kurtosis goes down. But for people who had a purpose, there was a protective effect of that. And we saw the same thing over here. If we had purpose, our axonal diffusivity, lower is better for this test. It went down with purpose, and normally it goes up with age. So feeling like you are participating and doing something good in your life is a good thing. And frequently around the world, as we age, we don't necessarily have the same participation rates. And then this just looks at stress and cardiovascular disease. So people who had low psychological distress have lower rates of cardiovascular disease, and people who have high psychological distress have higher rates. And we see this, and this really plays into the social determinants of health that Rosa Maria mentioned early on. And so it could be, stress from lots of different things. No matter what that stress is, it increases our risk of cardiovascular disease. And trying to find ways to combat that become increasingly important. And we also know that psychological stress increases our inflammatory markers. It increases cortisol, and which increases our blood pressure. It increases the likelihood that we're going to become diabetic. So these all have cardiovascular complications and consequences. And so we know that physical activity treats stress. So physical activity not only improves our muscle mass, reduces visceral adipose tissue, makes us utilize glucose better, but it actually treats depression and stress. So this looked at 50,000 participants, and it looked at PET scans of the brain. And what we saw was that people that had lower amygdala activation, and we followed them for 10 years, we see that stress-related neural activity goes down as physical activity goes up. And as physical activity goes up, we see that likelihood of having depression, clinical depression, goes down in participants who either had a history of depression or didn't have a history of depression. It treated both. And so what we see is that increased physical activity reduces the activation of the amygdala, which is associated with reductions in cardiovascular disease. So I know when I go out and go for a walk, if I'm very stressed out, if I can go out for a walk, especially if it's in a green space and it's in a nice area, I can feel my blood pressure go down. I can feel my amygdala go down. And I think it's important that we explain this to patients in this way as well. We also know that inflammation is reduced in people who have chronic habitual physical activity. And so this looks at multiple markers of inflammation, and it looks at people in different tertiles of activity. And what you can see is CRP, which is one of the ones we look at commonly clinically. The more active you are, the more your CRP goes down in habitual exercisers. Now, if you have a vigorous bout of activity, it may go up, but then it comes back down pretty significantly over time. And it's much lower than people who don't exercise. So again, we're targeting multiple pathways and reducing risk by treating each of these different risk factors. So if we go now to a sense of belonging, loved ones first, right tribe. This is the other thing that we talk about in the blue zones. The people that you communicate with and associate with are more likely to affect you. If they do positive things, you're more likely to do positive things. In the blue zones, most of the communities have a faith, have some sort of faith that they follow. They have some sense of a higher presence and that they're contributing to the world on a larger basis. And this was just a study from the United States that looked at people who attended a religious service. So people who never attended a religious service had the highest highest likelihood of dying compared to those who attended some religious service. And even if it was once a month, there was some protective benefit from that on mortality. And it probably had to do with all of the things that we just discussed, but having a network of people that you relate to and having a common belief in a common group that you can share things with. And that may be your family life, it may be something, a social circle that you're in, or it may be a religious group. But finding people that you can be around, especially as we age, is incredibly important. And this looked at social activity and mortality. And what you can see from this is that for everybody, the more variety we have in our social activity, the more likely we are, the less likely we are to die. And as we get older, that becomes even more important because as we're younger, there's more opportunities to participate in social activity, things like school and work. And as we age, increasingly around the world, we are more isolated and socially isolated. So those are also important things that I think we don't talk about very often. And then I think diet is one of the most important things. So in the blue zones, one of the things that they saw was that most of these populations had a plant slant. They weren't necessarily plant-based or vegan or vegetarian or whatever word we want to use these days, but the diets were about 80%, 80 to 90% plant-based. There was small amounts of wine, small amounts of alcohol, if any. And then there was the 80% rule that meant if you were 80% full, you listen to your body and you stop eating. And so we've talked about food as it relates to health for many years. This was a quote from Hippocrates, who's known as the father of medicine, but let food be thy medicine and medicine be thy food. And so if we look, 6 in 10 adults who are living with one or more diet-related chronic diseases, and CKM really is a diet-related disease. We know if we follow a Mediterranean diet profile, we can see changes in incidence of all-cause mortality. So people that followed a Mediterranean type diet, the most adherent for the longest, had the least mortality. When we look at the PREDIMED study, which is one of the largest population studies, which followed a low-fat diet, which was the control diet, and it followed a Mediterranean-style diet that was supplemented with either nuts or extra virgin olive oil, what we saw was significant reductions in the cardiovascular endpoint with either version of the Mediterranean diet. So as compared to a low-fat diet. And then if we look at a pro-vegetarian pattern in PREDIMED, because there's lots of different ways that people ate in the PREDIMED diet, but people who followed a more pro-vegetarian pattern or had more fruits, vegetables, and whole grains and less meats, we saw an improvements in mortality. And people who had very high adherence had the lowest overall mortality. And a plant-based diet in this day and age, unfortunately, doesn't necessarily mean healthy, though. So I think there are warnings from this because around the world, we're seeing unhealthy plant-based junk food or processed food. And so this looked at a plant-based diet versus a healthy plant-based diet, which is red, versus an ultra-processed plant-based diet. So if you ate an ultra-processed plant-based diet, which is, things that comes in bags, boxes, wrappers, what you saw is that's really less healthy than just eating a traditional diet, this gray line. Versus if you eat a healthy plant-based diet, we really do see some benefits from heart disease incidence. And so really what we need to think about is a overall eating profile versus just putting ourselves into a category. Rosa Maria already talked about processed food and really this concept of ultra processed food. And this is what we're seeing, especially in the United States, but increasingly around the world. If you think of corn as being minimally processed, canned corn maybe is being processed, but really things like Doritos or snack chips, fast food is really what we're talking about when we say ultra processed. So we know there was a large study, and there's lots of population studies looking at this, but this was over 44,000 adults. And if you increase the proportion of ultra-processed foods you eat by 10%, the risk of mortality went up by 15%. If we if we look at protein source, as the likelihood, if we add meats, and this looked at a lot of red meat as well, as meat went up as our protein source, our risk of cardiovascular disease went up. And if that protein source came from nuts and seeds, it actually went down. And if we look specifically at red meat and mortality in multiple studies, we see that as our servings per day goes up with red meat, and really when we're talking about processed red meat, our likelihood of having cardiovascular disease goes up. And so there was a great scientific statement earlier this year that came out from the AHA looking at dietary guidance to improve cardiovascular health. And it really says we should be focusing on dietary patterns rather than single foods or nutrients. And it really has additive benefits. So not only does it reduce cardiovascular disease, but it reduces dementia and stroke or dementia and cancer as well. And really that healthy pattern should be focused on vegetables and fruits, whole grains, healthy sources of proteins, liquid non-tropical plant oils, minimally processed foods, and then low in beverages with high amounts of sugar, saturated fat, and sodium. And so recognizing that food is part of our culture, we have to have a healthy eating pattern that blends what we enjoy and what we've eaten historically with things that we enjoy and that are reasonable for our life. And so a healthy, balanced diet really consists of whole grains, fruits, vegetables, lean protein, nuts, and seeds. And it's associated with reductions in cardiovascular disease mortality, which we want, but also reduction in frailty, which none of us want, reductions in sarcopenia, reductions in polypharmacy, improvements in cognition and mental health. And so the first thing we have to do is adjust calories to maintain healthy body weight, meaning that if our body mass index or visceral adiposity or whatever measure we look at is elevated, we have to reduce that. We should be eating plenty of fruits and vegetables, and in their most natural source. We should choose healthy protein sources, and we should shift from meat to plant as much as possible. And then we should add some fish and seafood, but fish oil supplementation is really not recommended from a cardiovascular disease standpoint. We should select low-fat or fat-free dairy products instead of full-fat dairy products, recognizing there is some controversy to this, but in general, when we look at many observational studies, this is what we see, but we don't see this in prospective randomized trials. If we choose to eat red meat, we should try to eat leaner cuts and avoid the processed forms of red meat. We should choose unsaturated fat in place of saturated fat. And things like replacing butter with plant oils and spreads has been shown to improve cholesterol levels. And we should choose minimally processed foods. And then we should try to minimize our intake of added sugar. So what we see is adults that consume more than 25% of energy from added sugar have a threefold higher risk of cardiovascular disease mortality compared to those who have less than 10% of calories from added sugar. And this is really what we see with processed foods. And then we should minimize alcohol. So we should never add alcohol from a health benefit standpoint. And if we can choose to consume alcohol, we should limit the intake and not do binge drinking as well. And then heart healthy dietary patterns result in lots of desirable nutrient profiles that really don't require supplementation of vitamins. They are rich in fiber, so they reduce our likelihood of colorectal cancers. That naturally limits foods high in cholesterol, and it automatically facilitates low saturated fat intake, so it should help with weight loss. And I really like the picture that they have from this because I think it's really nice to show to patients. So, first, we should maintain a healthy body weight. We should choose plenty of fruits and vegetables, healthy proteins, whole grains, and unsaturated fats. And we really should opt to minimize added sugars, sodium, ultra processed foods, and alcohol. And overall, this contributes to improvements in overall health. And so when we look at changing our diet, we generally see as we make improvements in diet, we generally see weight loss. And what we see is that when we change our diet to a healthier diet that much like the one we just discussed, or we lose weight, we see reductions in inflammation. So bariatric surgery was associated with significant reductions in inflammation with the weight loss. And then if we looked at, there was one other slide. If we look at people who change to a diet like this, we see reductions in inflammation as well. And then the other thing that we should talk about is cholesterol from a diet standpoint. We're going to have an entire session on cholesterol and dyslipidemias. But if we look at population standpoint and we look at hunter-gatherer societies, we rarely see a total cholesterol above 150 in any of these societies. And we don't think about this as being a normal cholesterol in the world that we live in, but the average LDL is about 50 to 75 in most of these societies. If we look at the average American LDL or total cholesterol is somewhere between 190 and 210, depending on where you live, with an LDL of about 110 to 130. When we're born, our LDL is about 30 to 70, depending on our genetics. And so probably this is where our LDL should be to prevent atherosclerosis. And so our guidelines have gotten closer and closer to this level over the years, especially our most recent guidelines from both the Europeans and the Americans. And we know that when we lower LDL cholesterol, we lower vascular events, and it doesn't matter if it's medicines or diet. We see a similar curve. We're more effective with medicines, and sort of this concept of LDL years I really like. So if we have someone who has severe hyperlipidemia, so we're thinking of familial homozygous hyperlipidemia, we may start seeing clinical events at a very young age. As compared to someone who may have moderate hyperlipidemia, we may not see events until an older age. But if we could live our life with a low LDL, we may never get to a clinical threshold for developing atherosclerotic disease. So I think this is also really important when we're talking to young people who have high LDL cholesterol about why diet becomes really important. When we look at dietary components in LDL, what we see is that solid fats tend to increase our LDL cholesterol. And that when we look at things that lower our LDL cholesterol, it's those things that we already talked about: fiber, soluble fiber in particular, like oats. We see reductions with nuts. We see reductions with vegetables. And unfiltered coffee is one of the things that I talk to people about sometimes because until I read this article, I didn't think about that. Filtered coffee is really neutral, but unfiltered coffee, because of the oils, can increase our LDL cholesterol. And so in our lipid guidelines that came out in 2026, we really talk about in adults and children, a diet that emphasizes intake of fruits, vegetables, nuts, legumes, whole grains, and fiber while replacing saturated fat and trans fat with mono and polyunsaturated fat is recommended to reduce LDL and ASCVD risk. So this happens to be the same diet we talked about to improve cardiovascular outcomes. So we know lowering saturated fat is one of the things that we want to focus on. And saturated fat is typically found in red meat, full-fat dairy, and coconut oil is the place in the plant world where we find the highest concentrations of saturated fat. So minimizing that, and we've known for many years that if we replace saturated fat with polyunsaturated fatty acids, we see reductions in cardiovascular disease risk. And that basically says all of those things. I'm just going to skip through these. If we add nuts to our diet, we can see about a 5 milligram per deciliter reduction in LDL. So one serving of nuts or less than an ounce. So I think that's something we can talk to individuals about. The portfolio diet, which added nuts, soy protein, fiber, and plant sterol enriched margarine, decreased LDL by about 26 milligrams per deciliter, just from a lifestyle approach. And then I think blood pressure is the last thing that we have to talk about briefly from a lifestyle approach. We know less than 120/80 is what we'd like to see. We know from population-based studies that as our systolic doubles or our diastolic goes up by 10, as our systolic goes up by 20 or our diastolic goes up by 10, we see increases in cardiovascular disease that double. And if we look at between 120 and 130, we see incremental increase in cardiovascular outcomes with increasing blood pressure. So from a lifestyle standpoint, if we lose 5 kilograms, again, we see improvements in blood pressure, about 4 millimeters of mercury over 3 if you average it over multiple studies in different populations. And we say for the best goal is ideal body weight if we're talking about weight loss. And if you get at least a 1 kilogram reduction in most patients, you'll see some reductions in blood pressure. And in general, you say about 1 to 2 millimeters of mercury for every 1 kilogram reduction in body weight. If we look at the guideline for blood pressure, the same diet we just talked about, which is rich in fruits, vegetables, whole grains, and low-fat dairy products, which is the DASH style diet, is very effective for lowering blood pressure. And this is one of my favorite pictures. It's an interesting trial that looks at dietary nitrates. And when we ingest dietary nitrates, that gets broken down to nitrite. Nitrite goes to our blood vessels and produces nitric oxide, which is what reduces our blood pressure. So foods that are high in dietary nitrates tend to be leafy greens, beets, all of the things that we put in those pictures that we've already seen. So this is a scientific reason for why the vegetables lower our blood pressure. If we look at a diet that's low in sodium and we say less than 2,000 milligrams optimally, but less than 1,500 gives us additional blood pressure lowering, we see between 3 and 12 millimeters of mercury reduction in blood pressure. And sort of the higher our sodium level, the more blood pressure reduction we see when we lower our sodium in our diet. And increasing potassium in our diet also improves blood pressure. So if we get 4 to 5 servings of fruits and vegetables, that usually gets us to 1,500 to 3,000 milligrams of potassium, and a DASH type diet typically gets there. Aerobic exercise also lowers systolic blood pressure, as well as isometric resistance exercise, things like sustained hand grip or chair sitting. So we get a few points with aerobic exercise, about 5 to 8 millimeters of mercury. Resistance training also gives us reductions in blood pressure, and isometric resistance does as well. So when we add all of these together, we see improvements in multiple different cardiovascular endpoints. So this is a document that I really like that is from the American Society of Preventive Cardiology and talks about practical nutrition information that you can talk to patients about. Maybe something would be interesting to you as well. And so over time, our population has changed. We've seen increases in body mass index, which have related to these changes in cardio-kidney-metabolic risk. We've increased heart failure as a proportion of cardiovascular disease, while we've seen reductions in ischemic disease. We also have new classes of medicines and higher statins. So now we have to focus more on this cardiovascular kidney metabolic axis to really focus on dysfunctional adiposity, improving lifestyle. We already said we have this new guideline that came out. And so in conclusion, CKM is common and increasingly prevalent. Dysfunctional adiposity is that very first step, and optimizing lifestyle prevents and treats the initial step in this cascade. So hopefully you learned something from some of these simple things that we talked about. And while we think of each of them as giving a tiny change, when we add them all together and we think about that over a lifetime, it really makes a huge difference in our overall risk, and hopefully improvements in our visceral adipose tissue.